Good evening. Thank you very much. I want to focus my time with you this evening on a topic that my colleague Esteve Almiral introduced before the coffee break around this idea of ecosystems. I'm going to use two examples. One where an ecosystem has been created in some very unlikely circumstances. And that is joint work with a colleague from the University of Sant'Anna in Pisa named Alberto de Minen. The second is to introduce a problem that I see developing, and others also see developing, that needs an ecosystem. And this is work with Eric Chen, who works at Onyx Pharmaceuticals. So two different examples, two different colleagues, all to share with you tonight. So let's see if I can get this going. Are we going? Yes, good. So my motivation. I wrote this book 10 years ago called Open Innovation that at the time was really looking primarily at companies and entrepreneurs and startups and the like. But the social sector has really been growing as a source of innovation in the past decades. That was one motivation. A second that we've already heard this evening and before this event at a World Bank workshop is it's much easier to start these innovations than to scale them. And so when we talk about these ideas of ecosystems, I think they're particularly relevant when we get to the scaling. And then this idea of an exit, not necessarily to make money, but to make it sustainable, to allow it to continue on its own once the donors have gone away, once the initial surge of interest has gone away, once new things that come in and might be distracting or enticing have played through. How do we sustain an exit? And then in the social sector, what do we do with the private sector and the public sector? And how do we see our role relative to them? So these were my motivations and what I want to share with you. My first example, this is an Italian nonprofit that does something very difficult. It provides health care in conflict zones. These are places that the Red Cross can't go to. That's how bad it is. Obviously, urgently needed stuff. Equally, obviously, very, very challenging to do so. So what they do, of course, like all nonprofits, they collect their money from donors, and the services they provide are not to the people providing the money. Those services are provided to people that the donors have never met. There's no connection between them. They also rely on very highly specialized trained physicians who very important talent management problem. It takes a certain kind of physician who's willing to work in a war zone. But the more interesting ones are how do you get into the war zone? And I'll talk about that in the next slide. You're operating in an environment where there may be no functioning government, for example. And yet you're going to be putting a facility in place, you're going to be putting highly trained personnel there, you're going to be moving in lots and lots of very valuable supplies and resources that you would prefer not be stolen the next day. How do you sustain that? And then what about the local citizens? This idea of, what was it, pro-poor, para-poor, and per-poor, really, really nice. I think that comes to the fore in this context very clearly. And then when you see about the exit, these people aren't planning to run these facilities forever. Their exit is to actually transfer it to the local community at the end. To do this, we've heard this term platform, and they use it here as well, but in a pretty specific way. They want lots and lots of buy-in and participation, to be sure, but there are some red lines that they will not bend. So even though they're very welcoming and very open in many, many ways, there are certain things that are very strict and very carefully managed. And so this combination of openness and this very strict discipline exists side by side to make this work effectively. So for example, bringing in the external money and technology, et cetera, that's taken from many, many different places. But once you're on the ground, no matter what's going on around you, there are certain things that have to be followed and respected in the facilities of emergency. They will not allow some of the perhaps local practices to go inside their facilities if it interferes with the practice of their services. And so, for example, the local authorities have to accept that some of the doctors could be women. They're not going to be all men. And in some countries, that could be a problem. That's a deal breaker from the beginning. If that's not accepted, they will not go in. They won't deviate from that. There are guidelines about appropriate behavior. So stealing supplies to take back to your family, which may need it, that's not allowed. Because you can imagine, once you start down that road, you set in motion a whole train of events you can't control. So there is absolutely no theft, no stealing, no pilfering, no borrowing from those. And even the international staff, if they've not been working with emergency before, they may have certain ideas of how they practice medicine that may be entirely appropriate where they were. Some of that may not apply here. And if that's the case, they have to adapt as well. So all this is done through training and negotiation, but it's really part of getting in. So how do we insert ourselves into a conflict zone where there may be no functioning government? And how do you make something that can actually perform and deliver valuable, needed medical services? Well, one thing is to figure out who you need to work with. And some of these parties could be not very nice people, even unsavory warlords, for example. But nonetheless, people who have, for better or worse, they need to be part of signing up to this. Now, one of the reasons to sign up, of course, is everybody gets sick, and it's in everybody's interest to have some health care. So that's one reason. But the second reason is Emergency's model does a lot of local hiring and training. So a second reason to do this is it's going to bring jobs and training to this area. And this is the reason why even some very hardened warlords might be willing to go along and say, yeah, if you're going to train these people and pay them money and provide services in the region, I'm willing to allow that to go forward. So once they get in and they're setting up and they're operating, they've trained their staff, the services are being provided, things enter into, it's not really fair to say a steady state because this is a pretty tumultuous area, but the model moves ahead and they have a lot of experience in many different parts of the world in doing this. What I thought would be interesting to share with you is the exit. And as we think about all these apps for cities, as we think of all these different enabled, democratized, citizen-based services we provide, it's interesting to think about exit or how it's going to sustain later on. So what Emergency does to make their services sustainable is that when a patient comes in, they make it a point not simply to treat the patient, they make it a point to get to know and to interview the entire family of the patient. And they view the family as part of the stakeholders in that patient's health and well-being. And through the family mechanism, they begin to broaden this idea of participation. It's not just the patient, it's the entire family that you're treating. Then, because they don't intend to operate these facilities for 50 years, their intention is once things are developed enough and enough staff have been trained, they will take their professional medical staff and their donor money and they will leave. And the clinics, the facilities, the supplies, and all the trained local people stay behind. That's the exit strategy. So that the services will continue to be provided. But we go from, maybe it was the pro-poor to the para-poor, and at the end we get to the per-poor stage at the exit. So at exit, it does sustain. Now, one interesting challenge they've had to deal with is when they get highly trained people in these facilities, these people now have a more attractive alternative career as well. They can go into their own practice, treat their own patients. And so they've had a certain amount of this turnover or leakage out to the wider environment, but they've accepted that as a cost of doing business, and to a certain extent it helps to create more acceptance of the model in general. So now to the second problem. And this 2 presentations ago, we had a wonderful discussion about health and the use of health data whether it's for treating diabetes or I have a close family member who suffers from epilepsy. And one of the things that I see as a need, apart from the data issues we just heard about, is in the last few years, after the financial crisis, the pharmaceutical companies in the US and Europe have really started to retrench. And they have literally walked away from entire areas of investigation en masse, with the effect being that there are literally thousands and thousands of compounds and projects that are stranded, nowhere to go. And the data and the IP rights, et cetera, are essentially locked up in these companies. And there's a lot of unmet medical needs. So in the field of epilepsy, for example, when a company decides to get out of neuroscience entirely, that means the prospects of new, better therapies for handling epilepsy go down, unless something is done, unless we can create an ecosystem. And this is where the need is here. The reason these companies are doing it is well known and not really in much dispute, which is companies are spending more and more on R&D, but getting fewer and fewer new chemical entities accepted. So there's a productivity problem. So you can understand from a private shareholder standpoint why the companies would want to focus and try to improve that situation. So they're not being bad capitalists, but for us as a society, there's a growing gap there. What you may not know is most of those costs that were in this chart here are not from the programs that get all the way through and go to the market. Most of the costs are in all the other programs that are started but don't get to the finish line. And all of those things that are worked on and all the knowledge that is generated right now sits inside those companies. The blue stuff at the end, the successful program, that does get out. And thanks to the patent system, those things are actually published and released, and once the patent expires, that knowledge is also available to the commons as well. But all the stuff in red is sitting inside companies unused and unobservable to everybody else. That's the challenge. Now, why do companies walk away? Sometimes it's not safe. Well, if it's not safe for humans, that's probably a good thing that we know that, and we may not want to subject humans to that. Although we're learning through better and better diagnostics that things that are unsafe for certain people can actually be tolerated quite well by other people. So things that were rejected 5 or 10 years ago, with better diagnostics, we could actually screen for and find the people for whom it might be very effective. So that reason may be interesting. Same with efficacy. As we get more and more knowledgeable about diagnostics, the genomics of 23andMe and these other companies, there's more things we can do and more ways we can segment and filter the people who really should not be taking this drug versus the ones that are. In other cases, the drug is fine, but the money's not there. Well, of course, in a group like this, that's a great opportunity for the social entrepreneurs to find the ways to take these and meet the medical needs, perhaps in a developing country market, so that maybe they can't pay for it directly, but maybe there are other mechanisms you can use to make it available to them. This is a bit of an eye chart, but it basically says, what if you could find a way to repurpose this compound? So perhaps it was developed for one indication, and at some point in its development, it got stopped. So, okay, the company says, we're not going to keep going. We got to put our money on better things. That's fine. What if the knowledge and information and the data on that compound were somehow made available for others to look at? And if one other party looking at this same data says, it didn't work for that, but I think it might work for this other thing over here, and then took that compound from the original developer and repurposed it for development in a different disease, a different use. You've probably heard some of the stories of these. The funny joke one is about the drug Viagra that was being developed for heart disease. And it turned out not to be very successful. And it, compared to the placebo, it was actually failing its clinical trial and was about to join the ranks of that red graph I showed you. But when they tried to get the pills back from the patients didn't want to give back the pills. That gave them the idea there might be a different market. That's what we're talking about here, where the drug doesn't meet its initial use, but it goes on to be very effective somewhere else. A more serious example would be the drug thalidomide that was given as a cure for morning sickness for pregnant women back in the 1970s. Sadly, that drug was associated with horrendous birth defects in the babies that were born. And that scandal really is what tightened the regulation of groups like the Food and Drug Administration, which previously were much more lax about reviewing drugs. That same drug, thalidomide, is now a frontline therapy for certain forms of bone cancer. So we don't give it to pregnant women, but we do use it for treating bone cancer. Same drug, two very different diseases. So if we repurpose a drug, we don't start at the beginning. We start in the middle, and then we carry forward from there to the market. And so what this chart is showing you is it would take perhaps less time, less money, and less risk if we repurpose in the middle rather than starting at the beginning. So it isn't just for society. There may actually be some good business reasons for this as well. How might this happen? This is admittedly a very abstract concept, but the idea would be to create some kind of an ecosystem. In this case, I'm showing the ecosystem as a social intermediary of some kind that receives the data from the companies that are abandoning the compounds, and in turn catalogs, curates, and provides that data to others who might be interested in starting in the middle and using a repurposed compound for many different reasons. And so the different parties in the ecosystem have different motivations for doing this. There might be some social policy to actually stimulate more use of this. And that could include, for example, a company that contributes a program that they've abandoned might get 6 more months on a patent for a product that they're shipping. Or they might get something called a priority review voucher that gives them a faster review for another drug they're developing. So there are mechanisms you could use on the private side to get companies to do more of this. And then on the demand side, a lot of unmet medical need. What they need are data that can be comparable to other data from other programs. And you've heard this a lot today, the importance of standards and getting data and benchmarking that you can do comparisons. Unfortunately, although the FDA does require a lot of reporting, different companies collect and store that information in many different ways. And this is an area where we need some harmonization and standardization so that on the demand side, you can compare program A to program B to program C for, let's say, diabetes that we were just hearing about, and see which of those might be the most promising for what you intend to do. So the ecosystems need some infrastructure and some commons to support them as well. For the CitiSense folks here, I think what I would invite you to think about and what this might mean for the work that you're doing. One is when we get into the social sector, this idea of who is the customer can be surprisingly complex. You know, is it the citizen? Is it the insurer? Is it the provider? Is it the family? Is it the warlord? Who is the customer? It can often be multifaceted. And so we have to be thoughtful about that rich context that we're working in. The second point I think I already said to you, but that the data are very complex, and we're going to, because of the very complexity of the data and the complexity of all of us as individuals, this is an area that needs a lot of work. Also, I think in the social sector, we're good at starting things. I think we have a harder time scaling them. And this is where I think exit gets so interesting, that helps you think through how you can get to scale and get to sustaining what you do later on. And indeed, I think if you think of the social sector situated alongside the private sector and the public sector, this is a great context for that, because oftentimes either the public sector or the private sector, or perhaps some combination, may be the exit for your social innovation at scale. Thanks very much.